Hello, everyone. I'm Louis Moss from EMR Direct, and I'd like to welcome you all today to ONC's Tech Forum working session. We have a great lineup of speakers for you today who'll be talking about the important topic of security and health information exchange. It's clear that maintaining both security and privacy becomes increasingly challenging as the health information networks grow and new exchange protocols are introduced. So we'll get a number of perspectives today on how each of the panelist organizations are approaching this topic. We're also looking forward to answering your questions, so please feel free to enter questions in the Q&A area at the bottom of this session screen. We'll try to answer some of them as we go along, and also save some of them for the end to challenge our speakers. So let's get started. Let me introduce our speakers today. First, you'll hear from Jen Behrens. She's the Chief Information Security Officer at San Diego Health Connect here in my own hometown, and the EVP of Privacy and Security at Kuma. She'll discuss how HIEs use governance and security controls to enable access to data while still meeting their privacy and security regulation requirements. We'll also hear from Mohammed Shibli. He's the VP of Connected Health Solutions at NextGen. He'll be providing us with an overview of HIE markets, services, and trends, and present privacy and security considerations from the technology vendor's perspective, including challenges that they've faced when aggregating data from multiple sources, an important topic. And finally, we'll hear from Lindsay Ferris, Program Director of HIE Projects at CRISP. She'll dive further into handling of sensitive data, especially under 42 CFR Part 2, and how HIEs can collaborate in the consent process to make that all happen. So without further ado, let's get started. Jen, you have the floor.
Great, thank you. I appreciate ONC giving me the opportunity to present. On behalf of San Diego Health Connect, we, through Kuma, provide Chief Information Security Officer services to a variety of HIEs and are very pleased to represent SDHC as leading the way in healthcare IT, information security, and privacy through comprehensive program practices. As a beginning, as we're opening this session, I wanted to provide you all with something of a level set of what is an HIE, why do we have HIEs, and then an initial perspective over some of the governance and security controls that we look to put in place at SDHC and throughout all HIEs. So why do we have HIEs in the first place? Health information exchanges are meant to resolve a problem that probably most of us as individual patients have encountered before, in that as we navigate an increasingly complex network of providers for ourselves, for our significant others, for our children, for our parents, if we're in that sandwich generation, increasingly they have different platforms, they have different forms, they have different languages they speak, yet you are in need to have all of that information in one central place, and then to have that information disseminated in an easy way so that your care can be continuous and hopefully more cost efficient. There was a recent study done, for example, in the end of 2019 that looked at the statewide HIE system in New York. And through those series of HIEs, or they're known there as RIOs, Regional Health Information Organization, there was an estimated $150 to $175 million cost savings for providers and ultimately patients by using an HIE, because the traditional siloed methods of sharing information is not only time consuming, but very manual and therefore cost inefficient. The other estimate that was even more shocking was that if all providers used the HIEs in New York to their fullest capabilities, so not just medical record exchange, but imaging and EMR, all sorts of platform integrations and EMT and different levels of documentation, that the potential cost savings for a year could actually top out at $1 billion. So HIEs were really designed to help that patient step out of the middleman role and having all of the increasingly interdependent and intertwined organizations be able to communicate with each other efficiently as well as safely and securely, which as an individual patient, even though I work in the security field, I'm much more willing to compromise my privacy and security if it's easy and if it gets me out of having to chase down different organizations and consent forms and mechanisms and who did I talk to when and what format are these in. And so it really is designed to help establish a set of rigor on that privacy and security that is needed and is regulatorily enforced. So the HIE was really designed to resolve a lot of issues that we see for patients. So what are HIEs? There are two commonly accepted different definitions, and I find this interesting that the HIE term can be used as both a verb and a noun. So the verb, and let's pay attention to the specific language as we're thinking through this session, is on security about HIEs and interoperability. So the verb about the HIE is that it is an appropriate and confidential electronic exchange of clinical information amongst authorized organizations. So there are some very key words in that. Similarly, as a noun, the Health Information Exchange is an organization with agreed upon operational and business rules that provide services to enable that electronic and secure sharing of health information. And so what, again, the HIE is designed is to be a way to enable and foster that secure exchange between all the entities to remove the patient out of being that middleman or unfortunately as a blocker sometimes, just as a patient doesn't know how to address the security requirements, handle their privacy settings appropriately. How do I pass on my privacy preferences? How do I make sure that all the different players in the network of our healthcare systems understand what my privacy preferences are? And Lindsay's going to get into a little bit more about that with their consent use case at the end, which is really exciting. It's been really wonderful to see organizations step up and try to tackle sensitive data sharing and consent and authorization mechanisms that work well with all organizations that are interconnected HIE networks these days. So I'm really presentation as well. So I asked you to remember some of those terms that were in those definitions about an HIE being both a verb and a noun. So I wanted to call those out. The key words that come to mind for me in this are that the appropriate and confidential exchange with authorized organizations. Also, the agreed upon operational and business rules, which is a key for you to think about a governance structure and a set of contractual obligations or a trust framework that has all participants in that HIE ecosystem working together so that they can enable and securely share those records throughout the system. So those words are very key in what an HIE not only does, but also provides. And those are also the key terms that we need to think of as the security professionals who work within HIEs. How do we accomplish those activities? What do those mean for our security program practices? And how do we think through those in terms of security? And one thing that I've done, and it's been very helpful, is to always come back to your base in security. So it's that familiar CIA triad that we all know and love: confidentiality, integrity, and availability. So if you think back again to those key terms, if you're looking at security and your HIE, you should be constantly thinking about how you map what an HIE does and what it is to our security base of confidentiality, integrity, and availability. So as the HIE pursues confidential and secure sharing of records, we need to think about the controls to put in place that align with that confidentiality principle of security. Similarly, when we think about the records that are being passed and shared should be done so appropriately and in accordance with our contracts, our governance, our trust framework to make sure that they actually represent the correct medical information that should be shared and it is up to date and current, as well as it is authorized to be shared. And that starts to get into our third principle of security, availability. So we work very hard to make sure that our HIEs have participants and that we manage our user access and our participants agree to certain standards so that those organizations are completely authorized and permitted not only to be in the network as a participant, but that their users are authorized to access the information. We have that other triad in HIPAA about access, use, and disclosure. So we constantly want to be thinking about our availability of authorized organizations and the users within those organizations, whether they can satisfy that right to access, use, and disclosure. And then we want to be able to enable that. That's a huge aspect of our HIE, is that enabling the technological feasibility to exchange records. And Mo, otherwise known as Mohammed, is going to talk a little bit more about that in a couple minutes when I pass the ball to him. And it's really fascinating to learn more about the complexities behind these networked organizations and the levels of controls that they go to in order to make sure that they are securely facilitating that exchange of information. It's really quite fascinating. And so I talked a little bit about we need to constantly think about the goals of the HIE operationally and how to accomplish a secure exchange of information along that CIA triad. And to that goal, we have two main buckets that we strive to satisfy. And there are various domains within each of those governance domains. And so what we want to make sure is that with any security program that we put in place, it is an integration of governance and security controls. If we do one without the other, the likelihood of success for a long-term successful security program is going to be minimized. And so we want to have our policy and our governance set up, and that includes contracts, which I know is everybody's favorite subject. So we need to, as security professionals, work very closely with our legal counsel and compliance officers to assure that our MSAs have security addendums that have a lot of that language in about the very specific security controls you see on the right side of this slide. Those security controls should be represented in your security addendums so that every participant understands their level of compliance that they need to operate with in order to satisfy those for the entire network and ecosystem. Of course, we have business associate agreements, and having those align not only with our MSAs, but within our regulatory frameworks, including HIPAA, but also any state regulations that may exceed HIPAA requirements. My favorite aspect of the governance side of things is risk management. And this is where I live frequently with my clients, is helping them understand their internal risk management. So how do they assess their compliance with all those security controls on the right side, as well as how do they externally manage the risk? So when I say that, as my role as CISO for organizations, I look at how do I reduce the impact of security risk that we have right now, and then lower the likelihood of accepting new risk into my system. And so by doing that and understanding that that is a big part of my role, I have developed a risk management program for my clients that includes risk assessment surveys and quality assurance for not only participants, but third parties. And so third parties is a somewhat vague catch-all label that can be used for vendors as well as subcontractors. And so at least every year, you should be performing an annual audit of all of those types of risk management activities and then updating as things change. In addition to that risk management and contractual side of governance are trust frameworks. Trust frameworks are a rather contemporary topic in governance and have different flavors to them. There are homegrown versions that different organizations develop on their own. There are certification schemas that are out there. Kentera has a federal identity management trust framework. And then one of the more common ones that this audience probably is aware of is TEFCA. And so these are governance documents that are meant to outline different participant and role levels of controls and business and operational practices that they need to comply with so that everyone has the rules of the road going in, and then there's a managed risk process for compliance against those trust frameworks. And different HIEs have different types and have piloted different versions. It's very exciting to see TEFCA rolling out and to see how that will implicate the practices of HIEs and their associated third parties. As I mentioned, there are a series of security controls that when you are looking at your security practices in your HIE, you should constantly think through. Access control, again, that enablement of the authorized users is exceptionally important. Your network security, so that you know that all your boundaries are strong and secure. Increasingly, mobile and asset security is an area that I have experienced organizations addressing and tackling because it's become an increasingly complex topic, especially given our work from home these days, and needing to look at how assets are being managed and what is being permitted to be accessed through those assets. Information security, software development security. Again, I know Mo's going to go into more of the technical aspects, but anytime you have some really brilliant developers and engineers working for you, you need to make sure that you have really strong software development security to monitor those really brilliant applications that they love to build for us. That touches on our architecture and our operations security, making sure that our developers and engineers and our operations teams are working in a safe and secure practice. Business continuity, disaster recovery, and incident response seem like no-brainers. Everyone should have them. They're in every MSA and business associate agreement I see these days. However, I think these are being increasingly tested as we're having smaller breaches affect more organizations, as well as the business continuity side of things, simply with whether organizations can operate in normal office structures within networks. If they're having to move to more of a continuous operations plan. Physical security is an interesting one these days, again, given everyone's work from home. So there can be some challenges around that. Some of my clients and SDHC have really done exceptionally well with monitoring physical security of workforce members through robust telecommuting policies and enforcement, including attestation and audit activities. So that's something I would encourage all HIEs and organizations looking to work with HIEs to seriously consider, especially these days and these times. And then that identity and access management, which is not necessarily the role of an HIE, but should be considered whether they want to own that or how they're going to manage that with a third party. And then again, make sure you use all of the controls regarding third party management to put in play that identity access management and then to manage how that is ongoing. And so those are some examples of the interplay between governance and security controls for our HIEs that we want to think about as we start to consider our robust ecosystems of networked organizations that are increasingly becoming paramount to healthcare these days. And with that, I'm going to transition to Mo for his presentation on some more of the technical sides of things.
All right, excellent. Thank you so much, Jen. Very nice overview. Hello, everyone. My name is Mohammed Shabli. You can call me Mo. Everyone calls me Mo. As Louis said, I'm with NextGen, and I want to just take a little bit of time to talk about kind of the vendor's perspective a little bit, and just kind of give you a little bit of insight into how we think about security in the applications that we develop and make available for our HIE customers. And I think if you attended the plenary sessions this morning, you've already been primed to start thinking about HIEs, hopefully in kind of an expanding role, in an expanding way. And one of my favorite quotes when I think about our customers, our HIE customers, and the HIEs across the country, one of my favorite quotes to think about is this one here about where power really comes from with data. So in today's environment, hoarding knowledge ultimately erodes your power. If you know something very important, the way to get power is by actually sharing it. And this could almost certainly be like a mission statement for health information exchanges across the country, where it's not just about building a geographical footprint or capturing a larger number of patients than your competitor. It's about sharing that data and making it available to those providers who need it at the point of care. And so it's really an important way for me to think about how we build solutions that the end goal is to ensure people can actually access the data at the time that it's most needed. And the HIE market, if you're new to this space or you haven't really thought about HIEs, if you've been in a framework of kind of EHR focus or app focus and you don't think about HIEs, you know, I think Jen did a great job earlier kind of setting the framework of why we have HIEs. I want to just expand on that a little bit to talk about some of the services HIEs offer and some of the challenges that actually exist in this space right now. As I think these are important to kind of lay the framework for some of the security challenges that HIEs have to consider. So if you think about what's the number of HIEs that exist out there, you know, Chic today, the membership organization that kind of aggregates and brings together the thought leaders and the leading HIEs across the country, has about 77 public HIE members. And this covers roughly 92% of the US population are covered by and served by a Chic HIE. But this market is kind of undergoing really a dynamic consolidation. We've seen mergers across HIEs getting together to expand their footprint, but really to join forces for economies of scale, for service consolidation, for a lot of different reasons. And HIEs are offering all kinds of new services to support that type of consolidation that's happening and really to drive their continued success. So we see really, and the key story that has been happening in HIEs for the last many years is, you know, it has to be a sustainable business model, right? We need to get away from kind of grant-funded HIEs, but they have to be sustainable and have a sustainable business model. What does that mean? Well, it means that the HIEs that have been successful have found ways to deliver value to their community without requiring necessarily that all of the funding comes from a government grant, but really comes from the community that's paying for the services that the HIE provides. And as part of this consolidation that's happening in the market, one of the key things we're noticing is that HIEs are expanding the set of services that they offer. They're becoming a lot more dynamic in the delivery of information. And so it's moving beyond just shipping documents from point A to point B. It's moving to more targeted information exchange that's needed at the point of care and delivered into an EHR. So we're seeing a really dynamic growth in counter notifications, in ADTs, certainly in document delivery, but in targeted alerts through the use of targeted messages right into an HIE workflow in many instances. This is not just a by chance or a random occurrence, but it's kind of a natural evolution over time. So as you have more endpoints in a community that need to connect, you really have to be more dynamic and more targeted in what you exchange. And so we've seen this natural growth over time, where if you just want to have a few endpoints connected with point-to-point data exchange, you can rely on just sending or receiving a CCDA. And that's pretty straightforward. It's relatively easy in that type of point-to-point connection if you have a handful of small participants. But as you cross certain thresholds and you want to start aggregating data and building a longitudinal view and supporting different interoperability standards and specifications, you need to get more involved in the type of exchange that's happening. And it needs to be more intelligent information exchange. Where we're seeing the market going right now is beyond just the models of centralized HIE versus federated HIE, which, if you're familiar with our space, those are really the two primary models for the HIEs that exist in the country today, right? You're either an HIE that aggregates data from everyone, and then you share records out when people need it, or in a proactive way, or based on a query and retrieve, or you're a federated HIE, which handles a query level exchange. Can I have a record for John Smith? And then the HIE is a broker of that connection to the source system that has a record for that John Smith patient. Those were really the two primary models that have existed and evolved over time for how the HIEs have more or less functioned. But where we're seeing the market go right now is more to this intelligent information exchange that's rules-driven, that's powered by FHIR, that's curating the data and really interested now in data quality and really evaluating all the data that's coming into the system to see if it meets minimum standards. And those HIEs, I think, are finding a greater level of success because they can deliver more targeted outcomes to their end users. And those HIEs also seem to care, and actually are caring more, about the combination of clinical data, financial data, and the socioeconomic data, the social determinants of health. Where in years past, we just, as an industry, I think we paid a lot of lip service to that combination of data, but the HIEs today that are marrying the clinical and financial data and delivering analytics have not only found increased ability to finance their operation, right, through new service offerings, but they're also delivering better quality results back to their community. So as a vendor, NextGen, we build HIE software. And there are a lot of different security considerations that we have to take into account that I think are worth sharing with you, just so you get a perspective of what it looks like to be in our shoes. But I think there are some normal and expected things that all vendors, any vendor you work with, has to check a number of boxes in order to be allowed into your space, right? And especially being in our industry, a heavily regulated industry, an industry that deals with patient data, financial data, credit card data often nowadays, as more of the portion of the payment is being, the burden of that payment is now falling on patients more and more. We not only have to worry about clinical, but also financial records as well in our systems. So as you're evaluating, as an industry, as you're evaluating who you're going to work with, there's some normal and expected things that you should count on from any vendor. And so from my perspective, when I think about how here at NextGen we build managed software that we release to the community, we have to think about the access to our systems and how we handle security really as a defense in depth type of approach. And this is just a strategy. It's not just one strategy, but it's multiple security measures to protect the integrity of information that we're managing. Information at NextGen, our software, our code base, access to our systems, the way that we control and protect all of our information, it's a multi-layered approach. And it tries to cover all angles of our business. Jen described a lot on her last slide, the different layers of physical and network security and access control and management and all of that. There are all these different controls that any vendor has to take into account. And it's really it's a layered security approach that, if you think about how, the Secret Service protects, their protectees, it's layers upon layers upon layers, like an onion that you peel back before you can access really the key part of, you know, the item that you're securing. So we have a multi-layered approach that involves physical security and application security and data security and all of that. But one that I want to add to that mix, which is something that as we've moved to the cloud over the last many years, is this idea of a well-architected framework, where this is not just a next-gen idea or a concept. This is something that Amazon Web Services and Azure Cloud, that they have a framework that supports good outcomes from a security and software development perspective. And it covers things like operational excellence. You know, do you have, as an organization, the ability to support your development and run workloads effectively on the cloud? Do you have security protocols that are built into, you know, the key aspects of how you actually deliver software? So for example, one of the core things that we do, and I think many cloud solutions do as well, is we really try to have a pipeline of software delivery that is a continuous integration and a continuous delivery pipeline. That's a term that's used in our space that says we should have the ability to release new software at any time, as quickly as we possibly can. Developers should be able to build, test, and release code out to customers pretty quickly. And the only way that we can really achieve that in a way that is secure and scalable and repeatable is if we have code checks and security built in at the point of testing, at the point of writing that code, and actually before pushing it out. It has to have the built-in automated security verification as a key part of the process, not something that is slapped on and added on later, but as something that's thought about well up front. And another part of that well-architected framework that is available from AWS and Azure, you can look at these documents, actually read them, and, you know, integrate those concepts into your operation, is also reliability and performance efficiency and cost optimization. And these things that you build and you want to support, they should be repeatable. They shouldn't be overly expensive. They should be, you know, you should have a way to manage how efficient, you know, your systems really are. So that well-architected framework is something that we, you know, have over the last many years really taken to heart as a key part of how we deliver our software. So that's kind of what every developer needs to do. But then, of course, because we're in healthcare, we have these two competing requirements that we have to protect the data, right? HIPAA and HITECH and 42 CFR Part 2, and that Lindsay's going to talk more about, and I'm going to tell you a little story about in just a second. We have to protect the data, and we also have to share the data. So all of our customers, you know, now are subject to the 21st Century Cures and information blocking provisions. And in my mind, I see the 21st Century Cures and the CMS patient access provisions. These are HIE permanence regulations. These are regulations that now make permanent this entire concept of a health information exchange as a noun. I see these two regulations as solidifying HIEs as a core part of the healthcare infrastructure. They already are, but now from a regulatory perspective, because we now have this requirement to, by default, make data available for others, because information blocking now says, you know, the sharing is the default, not the other way around. HIEs are going to be one of the key ways that that actually gets delivered, especially when we think about the CMS patient access rule that says ADTs have to be delivered by hospitals to the providers in their community. HIEs are just really such a great way to do that last mile connection. So those two requirements, protect the data and share the data, that's a key part of what we have to think about and when we're building software and releasing it. So quick story, I'll tell you just, you know, to maybe centralize this and kind of bring it home from a vendor's perspective. Let me just tell you a little bit about how we, from a vendor side, built our support for 42 CFR Part 2. And if you're not familiar with that regulation, it's basically a rule that says substance use disorder treatment data has to be handled in a very different way than just general clinical data. There has to be more controls around who can access substance use disorder treatment data and how it should be handled, whether or not, consent is given or not on that data, when you can break the glass to access that data from substance use disorder treatment centers, and so on. So Part 2 data, as the shorthand is Part 2 data, how it's handled by vendors, at least how we built our solution for it, required a lot of different thinking than other types of data that we encounter. The clinical, the meds, the allergies, the problems, and so on. It required us to complete, and this is something that happens not just on heavily regulated items like Part 2 data, but for all new features and new functions that we want to build, we have to do a number of deep dives with our customers, with our legal team, with our compliance folks. We have to do a number of different types of deep dives to better understand that function and that requirement. So there was certainly a regulatory review. There was the gathering of user requirements, which includes talking to customers, talking to clients and their end users. So if you think about from an HIE perspective, an HIE has constituents, right? An HIE has hospital administrators and nursing staff and physicians out in the community who are the customers of that HIE. And as a vendor, not only did we have to talk to our customer, but we also had to talk to the end user out in the community to find out, what does Dr. Jones working in the hospital, what does Dr. Jones need from this feature, and so on. And so that's gathering of end user requirements and performing the actual work of the interview and the requirements gathering and the requirements review was a key part of how we understood what clients expect after we understood what the regulation required. And then, of course, we had our technical design and our user experience and UI of actually designing what the screens and the features will look like. And that itself has a whole process of going back to the end user to confirm what we understood. So once we understood all that, we knew that the product had to segregate clinical and Part 2 data, had to be able to cleanly identify Part 2 data sources, but at the same time not reveal that Part 2 data may or may not exist for any given patient. And then we had to be able to support the easy administration of the user access and the roles for who should be able to access that data. And then, as with all Part 2 data, there's a really important audit and reporting requirement that if Part 2 data is accessed for a patient, you should be able to report to that data source that that data was specifically accessed. So how do you build a system that allows for all of that and provides easy reporting and low overhead to end users to configure? And one of the key challenges we had was this idea of managing kind of the provenance of all of that data. When you get data from a Part 2 facility, how do you handle it? And one of the key things that we've built into our application is really strong data fidelity, the ability to track the provenance of all the data that comes in, and then use that to aggregate a single patient record while maintaining that data fidelity from all of the original data sources. And so one of the key aspects of how we do aggregation is this idea of event sourcing, which all of the transactions that come into our HIE platform can be traced back to their original data source or the original API call or the original transaction, the HL7 message or the FHIR transaction. Event sourcing allows our system, unlike maybe a traditional relational database, right, where you have meds are stored in a meds table and problems are stored in a problems table and allergies are stored in an allergies table. Event sourcing allows us to handle clinical data as transactions. And we use then Elasticsearch to index all of those transactions so that we can quickly search and identify them. But rather than indexing meds as meds and allergies as allergies, we can build a single view of a patient's record based on all of the individual transactions that we've stored for a given matched patient. And on top of that, going back to that idea of defense in depth and layered security, we have these additional layers that we can add on top of clinical data that's stored in our system. As part of that patient aggregate view, all of the information we know about a patient, we can add features in our apps that allow you to limit how much data can be accessed about a patient. That's our data access constraints. Confidentiality at a code level, a diagnosis code can be identified as very, or highly confidential or just normal confidentiality. So you can limit at the data element level whether or not users can access that information. There's privileges and roles, and there's consent on top of all of those different permutations can be added together into a role that can be assigned to an end user. The key thing about all of that is when you've built up all of these features, you have to then be able to enforce those permissions, whether there's a FHIR call coming in for a patient to get a list of meds or get a list of problems, or get a list of allergies. You have to be able to enforce all of those layers of security, confidentiality and consent and privileges and so on. You have to be able to enforce all of those configurations, whether it's an API access, whether the user is coming in from a portal, whether it's data that's going out through Care Quality or a Sequoia project initiative like eHealth Exchange, or if it's happening through direct message. Can a user initiate a direct message that includes sensitive data? Well, that's all going to be managed by those layers of configuration that you saw earlier. And those are just some of the challenges that we have as a vendor and some of the thought process that we have to go through as we're building applications and delivering them out to our customers. And at the end of the day, one of the key things that I've noticed in my role is that, yes, all of those configurations and permutations, no two customers configure their system alike, and no two HIEs have necessarily the exact same mission or the exact same goals. HIEs, like any other evolving creature, they each evolve in their own ecosystem. And so they have different goals and different drivers for what is most important in their local community. And so one of the challenges we have, and all vendors, this is not just unique for us, is making sure that our system is configurable enough that we're allowing customers to do what they need to do, but not being overly prescriptive that we know what's best, because we've never found that to be the case. And that's kind of the end of my little session. My contact information is up if you'd like to reach out afterwards. But now I have the great honor of turning it over to Lindsay Ferris, who's with CRISP, a program director for the HIE, and she's going to talk to us about consent, just such an awesome topic. So Lindsay, all yours.
Thank you, Mo. And Jen and Mo did such a fantastic job describing health information exchanges. It really gives me an easy job here. CRISP is a health information exchange. We're a little unique in the sense that we have a partnership between CRISP Maryland, CRISP DC, and the West Virginia Health Information Network. And we have core technology that's actually deployed across those three regions. So today I'm going to be talking through patient privacy as kind of a use case as part of this broader panel discussion. And this is a topic that CRISP has been discussing and planning for and exploring for multiple years. So it's been a slow progression. And full disclaimer, none of this is live yet, what I'm talking through, but we're finally, I think, to a place where we're starting to execute on this and some of the details that I'll be describing a little bit later. But before I get there, I wanted to talk a little bit about the background and context of why it's been a slow progress thus far. And I think you've gotten some of that flavor from Mo's presentation as well. I think early on, the technical architecture that was deployed was one of the kind of barriers for us, and cross-referencing that with the policies that were in place, it made it really complex and difficult for us to be able to deploy, particularly with Part 2 data sharing with the very specific requirements outlined in that rule. And over time, CRISP has migrated, and we still use vendor technology, but we've migrated to also having an in-house development shop that where we deploy a lot of cloud-based open source tools and allows for us to more quickly and easily deploy new technology and configure features to what our needs are. We've also seen some policy drivers that have changed, first being the general designation modification to the Part 2 rule that allows for all treating providers to access Part 2 data through the Health Information Exchange. That was certainly a helpful modification to the rule. And then with the CARES Act, with better kind of Part 2 and HIPAA alignment, and particularly with the redisclosure rules around that, we're finally seeing a path forward where we think we can execute and start to share the Part 2 data. Beyond that, we also have seen the national network participation uptake and some of the policies that have driven that as well, including TEFCA, and it's starting to shape our kind of broader consent concepts and thinking through how we might want to structure consent in our region. One of the ideas or visions that CRISP has is having a centralized consent registry where patients can go once and designate what their consent preferences are. And then anybody participating, with a national network or data exchange within the region would have a place to go and centrally check to see what are the patient preferences related to that. And that's really to reduce a lot of confusion for the patient. It can be, I think, very confusing to maybe opt out of the HIE, for example, and then still have the data being exchanged through national networks or vice versa. Also, I think that the ONC CURES Act and CMS interoperability and patient access rule with increased patient access to their own data, it's going to naturally drive this desire for patients to have additional control over where their data is being shared and how it's being shared and with whom. And so with all of these kind of in mind, we've had we had the two areas kind of emerge that are our focus. And one is that centralized patient registry. But then also we see a very clear role for health information exchanges. And we have an HIE collaborative that was formed with our 3 regions, Maryland, DC, West Virginia, and 2 other HIEs, where we're working together to develop an interoperable standards-based open source platform that would allow for consent management. And there's 2 phases to how we're going to create this technology. One is through a provider-led workflow first, and that will help with capturing consents from a broad perspective, so general HIE opt-outs, also Part 2 consent for all treating providers through HIE for purposes allowed by HIPAA, and then also allow patients to consent for Part 2 data to be shared with their payers specifically. And then for the second phase, we're going to be looking towards a patient-led workflow where we're going to add a couple additional use cases to it, including additional kind of consent preference options, such as if you want to opt out of research specifically, and still have your clinical data exchanged, or with HIPAA authorizations, which will become increasingly important as we start to exchange social determinants of health data and navigating the HIPAA covered and non-HIPAA covered entities in that space. We have a number of development principles that are listed here on the slide. Really, it comes down to we're trying to make it as optimally flexible as possible. So, for example, the tool is designed for multi-tenancy. It can be hosted centrally by one HIE and leveraged by multiple different HIEs, and you'll still be able to configure the tool in a way that is very specific to the Health Information Exchange. We're seeing with the different technology stacks, as Mo was describing with the Health Information Exchanges, everyone looks different. And so being able to have that flexibility of how you actually insert that within your own technology stack and the Health Information Exchange is going to be very important. And there's also different interpretations or flavors of how the Part 2 rule, for example, would be configured, or there's different organizations and stakeholders that need to be factored into the consent process, and permitted uses of the data. For example, research might be allowable at one HIE, but not at another. And so providing that kind of flexibility in the design of this is ultimate for this collaborative. So my last slide is just kind of going through the actual design of the technology. I've split this diagram into kind of 2 different sections. On the far left with the shaded portion is really focused on the consent capture and store. And so they'll have a user-facing consent form where that individual will enter in the different specific requirements around the consent itself. So what their date range is, for example, what data they want to share with who. And then that's sent to the consent tool that's being built through this HIE collaborative and stored in the consent database. It's a FHIR compliant database. And not pictured here, but is also very important, is that that information is being captured for that specific individual is being shared with a master patient index. So it's processed through and connected to all the other data that's available within the Health Information Exchange, but not pictured here just for simplicity's sake. And then on the right-hand side of the diagram is more focused on the workflow around data access based on the consent. And so you'll have a different, services within each HIE. I have a couple examples of if a user were to go to a portal, either our, for example, HIE in Context Smart on FHIR app within your electronic health record, or a web-based portal, you'd log in and query for the patient. And then we tried to design the system in a way where the applications themselves that are displaying the information doesn't contain any complex logic at all. It's effectively completely blinded to any sort of rules around whether that information should be shared or not. And all of that's happening behind the scenes in the background through a series of very specific portions of our technology that I'll walk through here. And so at the time of the query, that's passed to an API layer. So what we're calling the API gateway within the CRISP world. And that gateway that will send the patient information to the master patient index. And anytime a patient has filed a consent form for particular granular consent, there's a source that's added to the master patient index for that patient. And with every query, we check the master patient index and say, does that patient have a global opt-out? In which case, stop, we don't need to show any information. Or is there a granular consent that's available? And if there is a granular consent, then it will go out and check the consent tool for that information. So it shields it a little bit from the volume. So we're not hitting the consent database every single time a patient's queried, but it's a little bit smarter and knows when it needs to go out and check. So if a granular consent exists, it asks the consent tool a series of questions. And this is going to be very specific to the Health Information Exchange architecture itself. So for example, if I'm collecting patient lists, so I know the relationship between a Part 2 provider and that patient, I know there's a relationship between those, and I know some contact information related to that particular organization. And let's say I also collect CCDA documents, and that contains all of the Part 2 information from a particular facility and being stored in a separate location in our infrastructure. The API gateway can be configured to say, can I show all medication or all clinical data? Can I show just the care team information or the relationship between the provider and the patient? And then the consent tool will have a translation layer that checks the consent database, which stores all of the individual consent configurations as FHIR resources. And the translation layer will just give a simple yes/no back to the API gateway. And if the API gets a yes back, it'll then go grab that information, either grab the care team information or grab that clinical document and send that back to the application. So that kind of concludes my portion. My contact information is here in case you have any further questions. And otherwise, I'm going to be passing this back to Louis.
Thank you, Lindsay, and thanks to all the panelists. We had a few questions that were answered in line here, but there's a couple more I'll pass along. Let's start with the interest on patient-facing access. Mo and Lindsay both alluded to patient access in the new rules. And Mo, also in one of your slides, you've also addressed that the FHIR and app integration is part of your forward path. I'm interested in, and I know it's a focus of a lot of the sessions in this forum, in how the technology vendors and HIEs are addressing patient access, including third-party apps where patients are accessing their own data. If your HIE or tech supports that, and if so, what are the additional privacy and security considerations that may come into play when you get into that type of interaction?
Lindsay, do you want to take a crack at that? Louis just asked.
Sure, I'm happy to
entire
talk.
Presentation's worth of questions.
I'm happy to take a stab at it from a Chris perspective. Sure. So we currently don't have any patient-facing functionality today, and that largely has to do with, I think, one, technology, but then also two, the patient authentication specifically that's required as part of that. We've historically done all of our kind of patient, any sort of contact with the patient has been through stakeholders and participants of CRISP. But with the patient access rules, we've started tackling this topic, and we're starting to think through it. So I'm not going to say it's a fully baked plan just yet. But the idea would be that we would have a portal as a kind of base level access. We would have to have a vendor that would be able to authenticate the individual and provide that access to their portal that would connect to our system through APIs. And then with the third-party integration, have that vendor also kind of manage that process as well. So it's kind of our thinking behind it. Basically have a vendor that can handle all those different requirements and steps, and we provide the data through an API connection.
Yeah, I think Lindsay hit the nail on the head on this one. This is a very kind of big and hairy and complex challenge. And I think when I think about our customers, our HIE clients, very few, if any, do direct patient access to HIE data. A lot of them rely on really feeding the data to the edge systems, their constituents in the community. And then the community, of course, is often just relying on the EHR vendor's portal, right? So it's an Epic MyChart or the NextGen Patient Portal or the Athena portal or so on. That portal may have data that has been facilitated through the HIE and delivered to the EHR. Going forward, though, with the patient access rule and other rules, in my seat, I'm also looking at, this requirement from our customers that the HIE should be ready to provide patient-level data access at some point in the near future. So I don't have a very good answer right now, Louis, to say we are going to do it in this specific fashion, cut and dry. There's going to be a lot of different layers to this, and we're going to have to work with customers to go through the full scenario that I described earlier, collecting those requirements, making sure that we are going to deliver something that's flexible and configurable to meet local needs, because it's going to have a different flavor everywhere that we look. So patient access is something as HIEs, as an industry, we've kind of shied away from and said, that's really an EHR problem for right now. But going forward, it's going to be our problem really soon.
And I will mention that one thing that, I'm sorry, Jen, that we're also focused on is that we have to do the patient authentication for the patients to access their clinical information, but we're also trying to make sure that we can reuse that authentication in other areas. So, for example, our patient-facing portal for consent. So instead of having to, authenticate the patient every single time in different uses or different ways in which we're interacting with the patient, we want to make sure that we can use that same authentication token across multiple platforms.
And to add on to the component of the question about mobile apps, increasingly I'm seeing with my HIE clients requests to integrate with mobile apps that are patient-centric and that can be integrated with the HIE and or the EHR platform. Interestingly enough, it depends on how those mobile apps are developed, who's directing them to develop, and who's managing that as to whether those mobile apps have to comply with HIPAA. And so ONC put out some interesting guidance on that last year. And you really need to look very carefully at how and why that app is being developed and who is playing what role in that, whether it's just a point of integration or who's actually driving the development. And those legal relationships will then permeate through whether those apps are within scope for various security and privacy standards of HIPAA. And knowing that there's PHI that's going to be flowing, you need to understand what the risk is between having an app that is HIPAA compliant and an app that is not, and then being able to articulate that clearly with your patients who, in my experience, patients presume any pseudo health related data is covered by HIPAA, and we know that that's not the fact if you actually look at what types of data is governed by that regulation.
Yeah, definitely, Jen. A few thoughts and related question, and also related question in the Q&A. So you mentioned, Jen, the apps and trying to determine if they're subject to HIPAA or not can be quite complex and depends on a lot of factors. I'll throw out as moderator here, I'm aware there are some programs being developed to provide that kind of accreditation to apps to validate their HIPAA privacy and security compliance, as there isn't really an ONC certification for such a thing right now, for example. I know ENAC is looking at something along those lines that might be helpful in that regard and could help those developers even answer those questions potentially, right, so that each HIE and health system doesn't have to go explore and do research to determine the answer to the question itself. So that's one thought. I was interested in what Lindsay was saying about the consent portal and the reusable consent across institutions. So I guess this is a question for Lindsay. Part and parcel with the reusability of consent is accurately identifying the actor, the patient. Who is it? And perhaps if you, across your 3 regions, there may be a common MPI or something of that nature that helps you keep everything linked together. But if you guys could touch briefly on how patient matching accuracy plays into your privacy and security concerns, especially when you're talking about consent and sensitive data and having certainty in that this consent really goes with this patient in your HIE and not another very similar patient. Is there anything that you could share with the group about considerations or perspectives on that?
Yeah, absolutely. I mean, it's a major focus. It always has been. We do have a shared master patient index across the 3 regions, and it's been operable for over 10 years now, about 10 years now. So we do have a lot of information flowing into it, which strengthens the algorithm, and we're all constantly kind of fine tuning it. And the idea would be that, we would collect enough information from the patient to be able to properly match that patient through our master patient index process, and extend that into the patient access world. And so it's definitely something that we're looking at and a focus on, and that we're very, very cautious of. I will say that there's a lot of different methods for how to verify, the identity of the patient and the information that's being collected. We'll have a baseline of information that we want to collect in order for our master patient index to properly match, but we might want to even think about strengthening, what information is collected and therefore matched into the patient, and making sure that we're displaying it to the right person. But those conversations are yet to be had.
Thanks. Mohammed or Jen, anything you'd like to add there before I go to the next question?
I'll chime in with one thing and then give Jen a chance to tag on afterwards. I think Lindsay's exactly right. There's a lot of different mechanisms that vendors and HIEs can employ to do that patient authentication. Matching against data that we know is certainly, a prime directive, something we could very easily do. The care team of the patient, obviously the demographics. We could present the patient with information about previous encounters, and you could go and click and say, yep, I know this one. I'm sure that's the correct data, blah, blah, blah. There's third-party solutions. There's Equifax and other kind of credit check-like things that can present the patient with data about themselves from other sources that they can validate. I think there are obviously industry mechanisms that work to do that. As I mentioned earlier, we have not yet deployed any of those as a core part of our applications just yet, but it is something that we're looking at. As far as EMPI questions earlier, how do we ensure that we have, the correct data about a patient? We've already seen with US CDI, the strengthening of, certain fields that can be used for patient matching. We're seeing some promising kind of regulatory movement around the inclusion of kind of like USPS level address verification, right? That can be used to improve patient matching. Research has shown there's good mechanisms once you validate addresses and use that for matching, you get better results. There's all kinds of things that we can employ there. At the end of the day, though, how customers actually decide to turn on, patient level data access is going to be up to the HIE, and I think local rules are going to be more prominent than just looking at federal regulations and HIPAA and all of that. Are the local hospitals going to want a competing portal alongside their portal that is now an HIE portal? So those types of policy things, forget about the regulatory rules, kind of having your local community agree that this is a good thing, right? If they're the ones funding the HIE, that may prove to be a bigger challenge than just deciding which, am I going to use Equifax's credit check service or TransUnion? There's going to be more considerations than just the technical. Jen, any thoughts you want to add?
I think you all answered pretty well. I work with several HIEs, and including a San Diego Health Connect. All of them are looking for the silver bullet on patient matching. ONC has several times requested comment on different patient matching and national patient identifier thoughts. Right now, we don't have one, which is why the market is developing. I will say that HIEs that do not have an automated MPI solution spend a lot of time on this problem, and it's a very significant level of effort that all HIEs are exceptionally committed to minimizing and assuring that the patient information is accurately tied to the correct patient. There are a variety of tools out there that is most suggested, from your traditional credit to different solutions that use more referential-based matching like Verado. And then again, you still have some of the old school, just manual matching process that takes a long time. So definitely patient matching, I think, behind consent and figuring out 42 CFR Part 2 might be in the top 3 list of conundrums for HIEs. And so it's definitely something that's very significant. It is also being taken into consideration from the identity proofing standpoint with our frameworks that are coming out, such as TEFCA, which does provide significant language around the level of authentication needed for patient identification for that patient access component. And so there are some fairly high standards in TEFCA when it comes to that. So I think it has established a very high bar, not one that is unwarranted or that hasn't been supported by groups such as HIMSS. And so I think there are a lot of different areas of interest in this topic, and hopefully we will continue to see progress on it. But it's definitely one of the top challenges I'm seeing for HIEs.
Yeah, Jen, thank you. I think you're right on that. And just to build a little on what you were saying, ONC does have a task force, Tiger Team, right now looking at patient matching and identity and some of those issues through the Fire at Scale task force. And I'm expecting they'll be releasing their final solutions in the next month or so. So definitely keep your eyes out to everyone who's interested in that. And your point about the higher bar, I think, especially with all of the recent security breaches and the widespread breaches of credit bureau data in particular, that KBV approach about asking questions has really gone away as something that is reliable anymore. And in the TEFCA identity assurance level 2, for example, that the use of KBV is extremely restricted and essentially, not available in that TEFCA model, or at least the proposed TEFCA model. So I guess we'll have to see where that goes. But the quality of the matching of the individual and plays in a way to the quality of the patient match, because a perfect match to the wrong person is really no better than an imperfect match to the right person. I agree with you that it is a conundrum. So thank you for sharing. A related question from the community here in the Q&A, Beverly Harden asks, what if the patient is not the one making their request and it's basically an authorized representative? Are there any other concerns here, and what is in place to make sure that that party actually has the authority is essentially the question. And I'll turn that over to anyone of you who wants to answer.
I mean, I can mention what I just learned recently, so I'm definitely not an expert, but when you go through the patient authentication process, we've been asking this question of our vendors, there's a mechanism where you can kind of basically do a virtual, one of the options is a virtual kind of authentication where you have a person join a video and they can show, that their specific detailed information, or upload their proxy information, the legal documents that makes them kind of an authorized representative. And then that's reviewed and determined that it's an appropriate sharing of the medical information. Or the individual themselves, if for example, you've got two individuals and somebody might be disposed later, but they can go in at this time and say, I want to share my information very specifically with this person. That can also be a mechanism as well. But it's something that I think the vendors have different solutions for that we're definitely paying attention to, because we know we'll come across it.
Yeah, and I could say not every HIE is prepared to try to authenticate either a patient or a legal representative, because it still gets into the identification game that HIEs aren't necessarily equipped to do or to manage. And so with HIEs that have that stance, the process is to refer that person and or their legal authorized rep back to the provider from where they're seeking the medical records. Since the provider is actually the creator and owner of the PHI, the HIE can reference them back to the provider. And it has, I think I'm seeing it about once a year, so I don't see it a lot, but usually it is a function of the HIE referring the patient and or the authorized rep back to the provider so that they can get the data directly from the provider instead of through the HIE. And as the covered entity, the provider more significantly owns that data.
Awesome. Thank you, Jen. And I have some good news here. I mean, this is unusual. This is the first working session I've participated in where the audience size has continued to grow through the whole presentation and through the Q&A. So I guess that means they're interested in what you guys are talking about. So let's keep going. There's another question about the ONC Fire at Scale Task Force from Viet in the Q&A, asking how different organizations are participating, contributing, and or adopting to guidance from the Fire at Scale Task Force, which I have a little insight into that as I'm co-lead of the security team there. But essentially, we touched on trust frameworks and cross-network exchange, and FAST is really looking at in a number of avenues of directory, identity, intermediary exchanges and security to facilitate fire at scale. I mean, on the order of, the scale, national scale. So if anybody has any comments on that, I think, Jen, you have some interest in that as well, if you want to start.
Sure. So, and I'll before I go too far, I will own I am not a fire or HL7 expert and don't claim to be. But can share that SDHC, San Diego Health Connect, is actively working on a grant with ONC called the LEAP grant to work through consent with fire and HL7. And so the HIEs are taking an active interest in making advances with the technology and the standard formats and language. So we're excited to participate. I'm not, again, the technical expert. I'd probably defer to Louis or Mo on that.
Mo, you want to add anything there?
I don't know how deeply involved. I messaged a member of our team to ask about the FAST task force specifically. I don't know how deeply involved we've been in that. Although we've been very involved in support for fire and releasing. We fully support R4 across our portfolio. I feel like that was, done pretty early and pretty successfully. We recently participated in the Saner IG work. That also is part of our Connect open source project and fully released. But FAST specifically, I can't speak to that just off the top of my head right now.
Okay, thanks. Go ahead, Lindsay.
I was just going to say, I'm also not an expert in this. I know CRISP is an HL7 member organization, and we have a number of fire resources and fire APIs deployed already today. But there might be other people formally participating at my organization I'm not aware of, but I'm able to speak to it in more depth, unfortunately.
Thank you. Let's go back to the Q&A board here. This is a general question. I don't know, any of you, you're all free to chime in. The question from Noah Ginter is about how to evaluate controls. If you have a preferred cybersecurity type framework that you use to evaluate them, or is it entirely a risk-based approach or a combination of things? And how does your approach play into, and does it remain consistent with anything new in the Cures Act around interoperability? So anybody want to start?
Can I volunteer Jen to answer that? I think she is resident security expert, without a doubt.
All right, you're on, Jen.
Thanks. This is a good question. It's one where I actually love to live with my clients, which they probably appreciate because a lot of people don't like this stuff. First of all, I think HIPAA is a beautiful regulation, and I think that it provides wonderful standards that can be risk informed. It also provides operational guidance on how to implement them. So I think that's a wonderful place to start. And that's how I have developed my risk assessments for different organizations, custom tailored to what they're each doing and the types of providers and vendors that they have. And so I make sure that I ask minimally, so the minimum bar for any third party and any participant is compliance with the administrative, technical, and physical controls of HIPAA. So it's just a good baseline and standard set of controls. Then what I additionally do is I look to see if there are additional controls that need to be added or addressed because of the type of interaction or integration that's going to happen. And some of that assessment and evaluation can be done through additional types of frameworks, such as HITRUST, which is everyone's favorite certification these days. And so we work with a lot of HIEs and healthcare tech organizations to get through HITRUST. Interestingly enough, a lot of our healthcare tech clients who are in that pseudo, maybe we're in scope of HIPAA, maybe we're not, also look to have SOC or ISO. And so we'll help navigate with organizations which framework, advanced framework to look at and how to map their alignment with HIPAA and HITRUST, or HIPAA and SOC, or HIPAA and ISO and HITRUST, whatever flavor they're looking for at that time, along with assuring that they're meeting their state regulatory requirements. A lot of HIEs are in states that have additional regulations as far as not only the flow of data, but the flow of healthcare related data, sensitive data, or just controls around HIE practices. And so we really make sure we account for all of those. And with the new, and Lindsay may be able to answer this better or differently than me. And so I welcome her and put on this. As far as looking at security controls with the new final rule on interoperability, the most significant one for me as a security professional is to make sure that none of the practices, the policies and practices that we're putting in place are a barrier or slow down or stop that exchange of data. One specific item is the exchange of sensitive data, and notably two types of sensitive data: behavioral health, which is more accurately mental health data, as well as substance use data, which is governed by 42 CFR Part 2. Those two types of data also have state regulations that apply in some states, but not in others. And if you're exchanging across a national platform, you have to understand what the implications are from a security protocol to make sure you're complying with your state security regulations while not blocking the interoperability and exchange of data across national formats or integrations. And so it's becoming more challenging, but it's also slightly more exciting for people like me that like to dig into those sorts of things and do different sorts of mappings. And I think HIEs such as CRISP, who are looking at how to manage that consent through sensitive data, such as 42 CFR 2 regulated data, is really the wave of the future.
Thanks, Jen. That's good. We're getting to the 10-minute mark here, so we'll try to plow through a few more questions. I think it's more of a comment here from Janice Karen about some conflation, perhaps, between patient matching and patient authentication in some of our comments. I'll speak briefly to that here. Obviously, patient matching is can be a component in patient authentication, but one thing we've left out in the conversation is, the actual authenticators. Once you've identified someone and given them credentials, like, are we going to be talking about multi-factor authentication, for example, or device-based authentication with, a number of cell phones now having things like built-in FIDO support and stuff like that. Is that anything any of you are touching on of how you actually affect the authentication step of entities or individuals trying to gain access to your networks?
From a CRISP perspective, we have multi-factor authentication enabled for all of our users already. So I assume that we'll continue with that. From the patient perspective, in terms of the different, in our discussion so far, and I don't know which direction we're going to really take just yet, but authenticating the patient itself, there's multiple ways to do that. So you could have a knowledge-based authentication. So something like the Equifax that Mo had mentioned earlier, or LexisNexis, for example, where you're answering kind of a series of questions to identify yourself individually. And then usually there's some other kind of mechanism for individuals where you can't actually do that. Either they're new to the country or they're minors, for example, and you don't have that information accessible. And then there's also kind of the point of care kind of verification, where you have an actual provider in front of a patient that can do that step for you, or you have a virtual version of that. So there's a lot of different methods to actually authenticate the individual and their identity. And then, of course, once you do that, then you have to properly match it to all the clinical data to make sure that you're showing that right information. So we didn't mean to conflate that or cause any confusion there. They're definitely separate, but can be related.
Thank
Okay.
you, Lindsay. And along those lines, too, one of the thoughts in the Fire Scale Task Force is around the realistic approach to try to create some kind of reusable patient credential, perhaps backed by a health system or even a payer or maybe even an employer, that can be reused across different HIEs or different health systems. And I'm just wondering if any of you have any experience or any thoughts or any plans around anything along those lines of federated patient identifiers or even federated provider identifiers for that matter.
Not around the patient identifiers, the provider identifiers. I think most of our platform level apps that HIEs use do support things like, third-party IDPs and SSO integrations, and we have nothing to do with the identity of that provider. It's really being managed by the health system or the upstream, provider directly. So long as we trust, the Imprivata or the Auth0 or the Cisco Duo or the Okta, system that someone else is administering, then you've got access. Now, that's obviously not the same thing, Louis, as what you described. But it's one step, I think, in that direction. So as far as like patients, that wouldn't scale for patients, right? You can't have that type of identity management. I would almost call it like naive level identity management. It would not scale for patients. So I don't know that we've gotten there yet. I think we're still looking at kind of the output from a variety of different work groups to see what is going to kind of take hold. I don't know that I have a direct opinion one way or another right now.
Great. Well, that's useful to know. And last question. We're down to 5 minutes, so just a quick 1 or 2 minute answer. Another topic that is increasingly of interest in the implementer community is this construct of bulk or population level data transfers. And that's not historically been the main focus of HIE transactions, although some HIEs do support this kind of thing. Any comments on additional privacy or security questions that come up when you're talking about passing thousands or millions of records, for example, to a government like the CDC agency or something of that nature? That's an open question to any of you.
I mean, don't do it unencrypted. I mean, you need to, from a security perspective, almost regardless of the size, but you need to really understand the flow of the data. You need to understand that it satisfies permissible use, why you have the data in the first place. Are you authorized to share it, disclose it? Again, getting back to those criteria that I talked about earlier, access, use, and disclosure, is that permitted? And then looking at your controls in place to make sure that it happens. These days with the pandemic, it's been interesting to watch the different waivers and extended release of enforcement over different public health scenarios for the exchange of data and who those exchanges are permitted to go to. So it's really fascinating. If you're going to participate in that exchange, you also need to make sure that you're staying on top of what guidance has been issued, because it does change, and it does change between the different states and the federal level. So from a governance side, you need to look at that. But then from the security control side, make sure that the flow of data is encrypted and securely done.
Thanks.
I'll add one
Mo.
thing to that. Not from the vendor side. One of the, most of our systems, and I don't know if I'm talking out of turn here, speaking for other vendors, but a lot of our platforms were built for single record exchange at a time, right? Not necessarily bulk record extracts. So I think one of the things that we're certainly looking at, especially with 21st Century Cures and the EHI export provisions and the bulk data export provisions of those rules, is how can we ensure clients can support, if they need 100, 1,000, 1,000,000 records, like you said, Louis, that does not, cripple their system whether in production or a read replica environment, doesn't cripple their system to run those types of exports, but also that those exports shouldn't take a prohibitively long amount of time, to the point where one of the exclusions around information blocking is around the infeasibility, right? Where I can't do it because my system doesn't let me. Well, we can't have that be a common occurrence. So it's one of the, maybe it doesn't directly answer the question about policy or rule or permissibility, but from a platform perspective, clients expect, if they're going to do exports, that they're going to be responsive and fast and sufficient to meet their needs.
Oh, most definitely, Mo. Thank you for that perspective. And certainly availability to other customers and other participants should not be compromised to try to answer one big query, for example. There's definitely a balance that needs to be struck. We're at the top of the hour here. I have a minute left. I want to thank all the panelists. And I know Alex Contour from ONC wanted to have a minute for some closing comments.
Sure. Thanks a lot, Louis. And thank you also to the panelists. I think this is another great panel, lots to think about, and did want to put in a plug for the next 3 panel sessions for this track coming up tomorrow. One looking at data integration and use, one talking about implementing FHIR, and then a final one looking at measurement and evaluation of interoperability. So we've got a lot of speakers lined up for you all, and hope you tune in tomorrow. Just a couple more reminders to close things out today. The plenary sessions begin again at 9 a.m. tomorrow in the auditorium, virtual auditorium, I guess. These sessions for the tracks can be watched in about an hour after the track concludes. So if you're like me and you thought this was great content and you want to take another look at it tonight, maybe while you're washing the dishes or something, it should be available to you. The platform will remain open for the rest of the day, and it should be accessible before the forum again tomorrow. And then please remember to fill out session assessments. There should be a link to a survey, I think, at the top of your screen, if it looks anything like mine, that has some very, very brief assessment questions that you can provide some feedback for ONC and our speakers. So with that, let's wrap up, and thank you once again to the panel, and thank you to the audience for sticking around through the end of the day on a Monday. So thank you.
Thanks, everybody. Bye-bye.
Bye.